Okay, great. So first we are going to talk about just a little bit about just what public health is generally. I'm sure many of us are fairly familiar with the idea of public health. It's been in the news a lot in the last year because of COVID-19. I think many of us probably know more about public health than we did a year and a half ago. But while responding to a pandemic is certainly one function of public health, there are many others, including surveillance of communities to determine how prevalent certain diseases or forms of violence or injuries are, upholding environmental health, so paying attention to soil, air, and water quality to ensure that nothing is going to make humans sick, promoting behaviors and practices that lead to good health.
Good morning, everybody.
I'm going to record. Anybody from Jesse's group want to share something you talked about?
You're going to hear me talk in a little while. You guys don't need to hear me talk for our group too. Amanda, do you want to share?
Sure. So we talked about different information sources that we get our information for presentations, RAIN, NISFS, CDC, things like that. And we were thinking about whether or not if there was an uptick in cases, what would be the causation for that? Is it pandemic? Could it be, media, kind of that thing of that, like if like the Me Too movement, things like that, people reporting more, what could be the reason why, and whether or not, our information is really accurate, how many people really want to actually disclose and that kind of thing.
Yeah, it is hard to, we'll probably talk about this a little bit more, maybe in our next session of this, but Jesse and I were having this conversation the other day about trying to figure out, what's the cause? Is it that there is an increase in cases, or is it just that folks are more aware of our services? Like parsing that out is really difficult, especially when the data we're collecting, we know it's incomplete to begin with. Anybody from our group want to share what we talked about?
I think Nikki from our group brought up a really valid point about who is believed. So I think a lot of times, like people can go to report and let's say it's a trans woman or a BIPOC woman, and it's like it's just not even written down. Like a police report isn't even taken because the belief is that it was consensual or whatever. But I really liked how they brought up, the fact that really believability really goes into the statistics and whose reports are taken seriously and not.
Yeah, thanks, Sophie. And this came up in the other group as well, just that when law enforcement is sort of one of the places we're catching a lot of data, like that's going to exclude so many people and so many experiences. All right. So the takeaway from this conversation, hopefully we're thinking about, obviously if we were truly looking at sexual violence from a public health perspective, we would be capturing a lot more data or investing more into fully understanding the scope of sexual violence in our communities, and designing better systems for surveying and surveilling like who this is happening to. The second piece that we are going to talk more about today as well is identifying risk and protective factors. That's like the second step here. So what are the risk factors? What puts somebody more at risk for experiencing or for committing sexual violence? And then the protective factors, the things that make it less likely that somebody will experience either of those things. And this also includes doing some research into figuring out why violence occurs, really understanding some of those root causes. That's all part of a public health approach. The third and fourth steps, while this is also a continuum, is to develop and evaluate interventions or prevention programs, response, things like that, and then to implement and to really implement on a scaled up level. So we're talking about not just you know, this like small group of people got some sort of prevention program, or they have access to the services and the response that they need. But really, we're talking about whole communities, whole groups of people that have access to these things.
Kelsey, do you want to share the Prezi again?
Ooh, sorry, it's not being shared. That's my bad. I do. Does that look fine? Yeah, okay, great. Sorry about that. All right, Jesse, go for it.
So we've done a little bit of work on this first step, right? This kind of surveillance, this trying to understand the problem. And many of you are probably way better versed than anyone in the public health field in terms of your understanding and your knowledge of sexual violence, right? In terms of what we know about what happens. Even if you know some of these things anecdotally, it's probably a fairly accurate representation of what's actually going on, because you're so experienced in seeing all these things on such a regular basis that it's just not being well captured necessarily, right? But there are some times that we don't actually know all the different pieces, and we'll talk a little bit about a couple of those examples. But I'm just going to quickly go over this because this is all stuff that you all know. So I'm not going to spend a lot of time going over burden, but I'm going to just show this like as from the kind of perspective of thinking about it from a public health standpoint, and as like why these kind of pieces are important. So really understanding the burden of sexual violence, right? We talk about burden of disease, and you've seen this throughout the pandemic. Like, what does actual like case numbers look like? How prevalent is the actual issue? And it's important to be able to understand that to know how to respond, right? So we have a pretty good sense of the burden, the broader kind of burden of sexual violence. And what we see kind of globally is similar to what we see nationally and locally here in Connecticut. So we're not so different, right? Which means like we're seeing a very pervasive problem throughout the world. Some people might call it somewhat of a pandemic, right? Although it doesn't shift. So I kind of like look at it more as endemic, which means that it's constantly kind of happening. It's something we kind of expect to happen. And I call it, I was sort of looking at it as like epidemiologists might actually refer to it as hyperendemic, because we see really high rates, and these high rates are persistent, right? So 1 in 3 women experiencing sexual violence throughout their lifetime is incredibly high. So you all know this, I'm not telling you anything you don't know, and 1 in 6 men, right? And as we start kind of thinking about and breaking down to understand better, what does that look like? Because we know that everyone experiences sexual violence. We know that it really knows no bounds, right? Like it's across gender identities, it's across race and ethnicities, it's across nationalities, it's across immigration status. We know all people can experience sexual violence. However, we do see certain groups of people that have greater, maybe carry greater burden. And some of that we know could be based on some of their experiences and historic oppression and historic, different types of discrimination. However, some of it also is not always like clear what the reflection is like, because there are limitations in many of the data sources. So we'll talk a little bit about that too. Kelsey, can you go to the next slide? So with some of our, so with the NISFIS data that you all are fairly aware of, right? The National Intimate Partner in Sexual Violence survey that CDC does. Some of those limitations are that they only survey those 18 and older. They do ask retrospectively to get some information, and it's only done in English and Spanish, and for those who are non-institutionalized. So we really don't get a sense if someone is in a hospital for mental illness, if someone has been incarcerated for a long period of time. That survey is not capturing their experiences of sexual violence. And we know those rates of sexual violence are much higher in some of those populations, right? That like persistent trauma that leads to experiences of being in the system, we know are much higher and are not as well documented in these types of population level surveys. CDC and others kind of, these also are pretty common estimates of 1 in 4 girls, 1 in 13 boys. We know that within experience of sexual violence, they start earlier, right? We know that most young people experienced their first experience of sexual violence before the age of 18, and that tendency towards, or that experience of sexual violence increases later in adolescence, right? So when they go from like 15 to 17, there's a study that was done nationally that showed that rate increased quite a bit from when someone reported at 15 versus when a group of students reported at 17, and that rate had increased fairly dramatically. Kelsey, can you advance, and then it will zoom in and then to the next one. So this is specifically taken, I wanted to pull in as much Connecticut level data as possible. And this is something that you all can take a look at. We'll share this, the link with you, but on the CDC's website, you can pull up the Youth Risk Behavior Survey data, and you can look at national data from the Youth Risk Behavior Survey compared to Connecticut data, which I think is like pretty interesting and kind of telling, where either there are places that Connecticut is kind of right on par with the rest of the country, and then there are places that Connecticut's maybe doing a little bit better, and maybe places that we're struggling a little bit as a state. But this also pulls, you can look at the Youth Risk Behavior Survey from Connecticut, specifically between, they only show it as a gender binary, although I know they collect the data slightly differently than that. So you can look at that. You can look at sexual orientation of students who completed the survey, and you can look at race and ethnicity breakdown. So there are a bunch of different things that you can do, and you can play with the data fairly easily on that site. So if that would be helpful to you, what it doesn't do is show you anything at like a lower like breakdown of like geography. So we can only look at Connecticut level data through the Youth Risk Behavior Survey through CDC. There's nothing on county, so you won't be able to look specifically to your catchment area, but you can look at what's going on across the state. None of these data, I'm sure, are surprising to any of you, looking at whether that girls have more than twice the rate of ever having report twice the rate of being physically forced to have sex in their lifetime. That's an ever, so that's a lifetime measurement that they respond to. And then for the middle graph that you're looking at, they experience sexual dating violence in the past 12 months. That's of those who actually report that they're dating. So that looks at like a slightly smaller group of students, right? So of those who are dating in the past 12 months, we're looking at, again, more than twice the rate among female students and male students. And I put in the physical dating violence, so you could see that girls are experiencing much higher rates of sexual dating violence than physical dating violence in their dating relationships. On to the next one, okay. So again, for many of you, you've sat through multiple presentations or trainings that we've done over the past year, where we've been talking more and more about adverse childhood experiences. And I think many of you are already familiar with that term, but for anyone that's new to, this is a measure of looking at experiences during childhood, so under the age of 18, that are potentially traumatic events, right? So many people would look at some of those events and say, I think that even divorce of parents is listed as one ACE. And I think, we see divorce is so common in this country that a lot of people don't see it as necessarily an adverse experience, right? But it is listed as one of those experiences. They also look at things like, child sexual abuse, child physical abuse. It's all types of maltreatment. There's the incarceration of a family member, death of a family member. So all those types of things that, we all kind of know could be potentially very traumatic in a child's life. And through the initial ACEs study, which was completed, the initial study looked at, was like a very large study of an HMO, which had many limitations. I'm gonna put those in there too, because I think it's really important to note, because we all use a lot of in this field, we like to look at the ACEs data and use the results of that study, because it's one of the only ones of its kind that really dove in deep to try to understand adverse childhood experiences and what that meant long-term for people's health outcomes. But that study ended in 1997 and then kind of followed up for many years and looked at those individuals who were participating. But 2/3 of those participants had experienced at least one adverse childhood experience in their lives. 38%, so almost 40%, right, experienced 2 or more ACEs, and 21% experienced sexual abuse in childhood, 21%, right? And what they showed in the study was that these adults that they were talking to were looking retrospectively at their childhood, and they were able to link the experiences of child sexual abuse to experiences of sexual violence later in life. They also were able to look at it as a link to other health problems like chronic disease and mental illness and substance use. So this has been a really important tool for public health to be able to say, hey, look, this is pervasive and it's like going on in childhood, and it has immense impact throughout life, right? And how important that was for this movement and for this work and those who do anti-violence work to be able to say, this is a critical problem and it starts early. And it links to all those other things that you public health people think are so important and put so much money into. We talk about chronic disease and we talk about substance abuse and all those things that are really important. Well, they're linked to early trauma and we're not paying attention. So this gave a number of groups and movements really the data to be able to say, look, what we're talking about is really important. Okay, next slide, Kelsey. So when we look at existing data and like NISFIS data or even the YRBS data, they show those data show slightly higher levels of sexual violence among a couple of groups of color: American Indian, Alaska Native, and those who identify as multiracial or identify with multiracial and non-Hispanic. However, one of the things I will say is like with the ACEs study, many of our studies are undersampling in communities of color. So the ACEs study was almost predominantly white, and it was all folks who had insurance, right? So it was within an HMO. So we were looking at a very specific cohort of individuals who participated in that study, right? That's a huge limitation to being able to understand the extent of ACEs in the broader population within the United States. So I just think that's really important. And you all know this, but this is a question that I kind of put in. I used a similar slide in a class I taught, and we know, I think you all will be able to answer this question, but is sexual violence even more underreported among people of color in communities of color? And why do you think that is? What do you think fuels the fact that like half the time, I think, not half time, I'm totally making that statistic up, but many times that we don't have as good data on communities of color? Why do you think that might be? You can put it in the chat too.
Trust.
Yeah, or lack thereof. Yeah. Yep.
Are you holding that out to anyone in general? Or are you asking someone specific?
In general, to all of you.
So there's a lot of the cultural approaches are just off in terms of how they go about gathering the information. I would say that's very similar to kind of when we ask about intimate partner violence, and we've learned now we can't say, have you been a victim of intimate partner violence? Everybody says no. You have to go, you ever been in a relationship with somebody and you argued? Have you ever been dating someone and you either slapped or pushed them? Has someone ever locked the door and you couldn't get out during an argument to keep you there and continue? You know how we had to go there with that and realize that people didn't identify all of those things as domestic violence? You know, nothing clinical, no statistics, but just in my own personal experience and kind of doing that work in a personal level and on my work, I've seen kind of the same thing around people dicing up what is sexually inappropriate behavior. And then it's reinforced. What I have at least seen is even adults saying that's nothing, that's not a big deal. Particularly when you have other children, peers, teenagers as the perpetrators. You know, there's a lot of ideas of what did you do? So you have people walking around carrying this, you know, the response has been, well, what did you do? And they figured out, oh, I did something wrong. I wasn't attacked, or I did something to bring this on, that doesn't count. And I've actually heard that before. Well, that didn't count. You know, well, that was my stepbrother and we were the same age and they were just running around and acting silly with everyone. I'm like, oh, okay, all right. Don't see that as okay, you know. There are just so many pieces around that. And then on top of that, you have a really nasty history, and then I'm going to be quiet because I can go on and on. Really nasty history of African American men being accused of sexual violence as a excuse for lynching, arrest, things like this in the past. You combine that with the idea of trying to protect your community, not holding people out to dry. Actually, seeing people say, well, you know, why would you go ruin somebody's life like that? And you combine that with just what is really poor prosecution for women victims. You go to court, everybody knows your business. You have to go back to your community. And oftentimes there's not any prosecution. And if you look at the response and prosecution rates for domestic violence, things that are visible, you know, people who have been injured and the lack of judicial accountability for those perpetrators within that community, why would you even try to convince somebody else that you had actually been raped and you weren't beat up or dragged somewhere by a stranger? So that's what at least I've seen in terms of my work and my personal life with, you know.
Thanks, Brandon. You hit on like so many, so many points and so many important points, I think. Thanks. And then there's a bunch of great additional points in the chat too. Cultural differences, rooted in systemic racism and sexual violence from white people in power. That's sort of part of what Reina was saying too. I mean, yeah, all the way back to slavery, right? We all know that that slave owners were raping their female slaves all the time. And there was an incredible amount of that was going on, and that has persisted. We also know, like Reina was saying, that there was a study that was done at Michigan, I think University of Michigan. I'll pull up the study and send it to you all if you want it, but that really looked at the wrongly accused and Black men around sexual violence specifically, and Black men in particular. It was like something like 75% of those who had been wrongly accused were men of color. So it's been documented repeatedly. It's a humongous problem, and so of course there's underreporting. No one should be surprised by that at all. And then again, we like kind of what Reina was talking about, the way that we ask questions and the way that we approach sampling of communities. And then you look at the history and look at what's going on right now in terms of hesitancy around vaccination. There's like a lack of trust with, and public health has a lot of work to do to be able to regain trust among communities of color, right? And so there's so much historic exploitation and harm that has been done to communities of color that gathering accurate data is really challenging. It's really challenging, and for good reason. Okay. So, unfortunately, we can't look at this from a Connecticut standpoint, but this is national data that looks specifically at trans students. So again, this is from the Youth Risk Behavior Survey that looked across high schools from across 10 states and 9 large urban districts, and just look at these numbers. They're just crazy. I mean, this is just, it's just appalling. And we see these sorts of distinctions in terms of the experiences of young trans students, as well as LGBT identifying students too, when it comes to experiences of violence, reports of like different mental health indicators. So different rates of depressive symptoms, suicide attempts, bullying, fear of going to school, all these different things that are all interrelated, right, to their experiences of oppression. And we see these incredibly high rates of violence among many youth that experience oppression. And then the other statistic here, the 47% of transgender individuals reported lifetime sexual violence involving physical contact, comes from a national survey of adults, and again speaks to like these incredibly high rates that we see among transgender populations who are woefully underserved.
Oh, sorry. There you go.
So again, this is not going to be news to any of you, although I think, you know, this is one of the areas that we have a lot of work to do is in terms of reaching and securing trust, not dissimilar from communities of color. We have to do a lot of work to secure trust among LGBTQ individuals and how we can best serve them, and showing, kind of like Rena was talking about with culturally specific, the ways that like the culture and how we ask questions. You know, how many times might someone who is trans come into our space and be like, this isn't my space, like I don't feel comfortable, right? Like the ways that the anti-sexual violence movement has framed this work over the past and for many, many, many decades, right, of being a he-she situation and it being this very like, binary and dichotomized perspective, really excludes a lot of people's experiences from the work, right? And so we have a lot of work also to do to be able to serve these different groups of people that we're seeing are experiencing these incredibly high rates of violence. The next one, Kelsey. So someone brought this up in the chat, I think it was Sarah. We know that, again, another group that is undersurveyed and underrepresented in terms of their experiences, people with disabilities. This specifically was a kind of an investigation that was done, I think, through like NPR, right? I'm trying to remember when it was. It was a few years back, and they had, I think, sought out the data specifically from the Bureau of Justice Statistics. It wasn't necessarily data that had already been put into a report. I think they actually had requested it, and this really speaks to kind of this like incredible disparity that people with disabilities also experience in terms of violence, right? And especially around sexual violence. And look at the rates at the top are looking at persons with intellectual disabilities, and just that these numbers also are incredibly staggering, right? So we're looking at 4.4 per 1,000 people that experience sexual violence. Or I think this is actually specific to, to the rate of rape and sexual assault, compared to those with no disabilities, which was as the rate is 0.6 per 1,000, right? So we're seeing these incredibly high rates, and among those with intellectual disabilities, about 12 times the rate. So Kelsey mentioned this in terms of we're talking about burden, the economic burden and the costs associated with it, and then the investments that we make, or the lack of investment, I would like to say, that we make. And this is a breakdown that CDC had done looking at the lifetime cost of rape. So the estimated cost per victim times all those that are reported in the US and what that means. And the number that they've kind of modeled or estimated is 3.1 trillion in lifetime costs. And I just did a quick, did some quick math, and that's about 1/6 of the national debt. So what we could be doing to help relieve our debt, right? I mean, part of this is just a matter of prioritization, right? And this has never been high on our list of priorities as a culture, as a society, and nor has it been high on the list of priorities for public health. And only in much more recent years, maybe the past decade and a half or two, has public health really started to even recognize their role and the importance of addressing sexual violence within the kind of context of public health. Still me, right? Mm-hmm. Okay, and this again, this is going to be some review for, or maybe review for all of you, but I kind of wanted to highlight how critical this component is within the context of public health. And so, Kelsey and I talked about how we wanted to make sure that we kept this in this presentation, even though you all are much more the experts in understanding this piece, right? Like, this is more stuff that we have to share with people in public health, and reminding them that there is the consequences, the trauma, the long-term impacts, right, that we talked about with ACEs is so real, and it covers, it's across these different areas, right? We're talking about physical trauma and consequences, we're talking about psychological and mental health issues, talking about behavioral components, which could be, something like engaging in less safe sex practices, for example, or taking just like more risky behaviors. We talked about, I saw something at one point about higher rates of not using seatbelts among people who had experienced trauma and sexual violence. And then, the more social kind of consequences, right? And this you all see all the time when you're working with clients around readjusting to workplace experiences, like they've gone out of work for a while because of their experience, the way that they see relationships deteriorate, a lack of safety and power and trust. So all those different pieces, right, are the pieces that we're talking about here. So I think many of you have probably seen this. I borrowed this from one of Elise's slides. I really love this quote on trauma and about how traumatic events are extraordinary, but not because they're rare, but because of what they do to our lives and to our bodies, right? And I'm not sure when people are thinking about this on a regular basis, they're thinking about that piece. They're thinking about what the impact is on bodies, on our physical, mental health and well-being, and how people who have experienced trauma then are able to navigate the world and relationships. So this, I think it zooms in a little. I'll say if you go to the next. In terms of this is, really looking at trauma and public health effects. So this, we use wheels a lot in the anti-violence movement, right? Like, we like to kind of put things into this kind of model, which I'm not entirely sure where that came from, but in terms of violence and these experiences, this is really looking at these different health impacts, right? So that I just kind of talked about. So, and this is just giving some examples of those. So from a mental health perspective, we're looking at injury, so physical outcomes. And then the one off to the right that's kind of on the side, we're looking at non-communicable disease and risk behaviors. And this, is one of the things that really came out of the ACEs study, is this connection between experiences of violence, especially in childhood, and various chronic diseases and non-communicable diseases that were how would that even be related to each other, right? We see this very clear connection to increases in cancer, increases in the risk of diabetes and heart disease and chronic lung disease. And so that's sort of what that section is speaking to. And then communicable disease and risk behaviors, none of these are going to be all that surprising to you. It could be directly resulting from the trauma, from the violence, right? It could be a sexually transmitted infection, or it could be something that's a little bit longer term or medium term of an impact, because the experience of violence has led to taking, like I just said, engaging in more risky behavior. So alcohol and drugs gets involved. We know it doesn't cause sexual violence or someone to perpetrate sexual violence, but it can impede our ability to make decisions. So alcohol and drugs, unsafe sexual practices. So the STI might come later, but it might be because someone has engaged in less safe sex practices following their experience of violence, which also may be in or out of their control, right? And then maternal and child health issues. There's a high rate of unintended pregnancy among those, especially those who experience sexual violence by an intimate partner. We see much higher rates of unintended pregnancy from those, and other types of reproductive coercion.
All right, so the social ecological model is probably something everybody has seen before. This is really useful in both thinking about how to prevent sexual violence, which we'll talk about in a second. But we can also think about trauma as occurring across the levels of the social ecological model, right? So there's obviously an individual experiences trauma when they experience some form of sexual violence, but this trauma also affects people's interpersonal relationships, right? How that person functions within their family, within their intimate relationships, within their friendships. There's consequences there. We can think about how sexual violence, whether it's a specific incident, maybe that many people know about, or just the sense of an ongoing problem of sexual violence, or folks being not feeling safe because of the threat of sexual violence, how that then affects our communities and our society, right? Prevalence of sexual violence also, influences the reputations that exist for certain locations or communities, right? If you think about on college campuses, right? The high rates of sexual violence. We think about men who might be involved in fraternities or play on sports teams, right? There's certainly a community impact of sexual violence at that level, right? And that I think we were talking about this a little bit earlier with the Me Too movement and with really highly publicized cases of sexual violence, that leads to trauma for folks, not just people who are survivors. It can be triggering and re-traumatizing, obviously, to hear about these experiences in the media all the time, but also for folks who are not survivors, like to live in a world where this is just an ongoing problem. All right, so we're going to shift now to thinking a little bit more about how we can use a public health approach, and specifically part of public health is like breaking down silos and approaching work from a really collaborative way, thinking about that there are many, many different people who need to be involved in solving a problem. So we're going to shift to kind of thinking about how we can be doing this work more effectively. And this we are seeing on this slide, the social ecological model again. And this is really also to remind us that we cannot end sexual violence without addressing each sphere in this model, right? So many of us here are doing prevention programs that might be, if we're working with students in schools, like really focused on building individual skills and helping folks recognize how they can set their own boundaries and respect other people's boundaries and things like that. But we also know, and I'm sure many of our community educators have felt this like tension or frustration before, that we can teach students lots and lots of skills, but then if they're going home to an environment where somebody that they live with is repeatedly breaking boundaries or harming them, then our prevention lessons in schools are sort of only going so far to keep people safe, right? So that's why we need to also be addressing, and this is not the work just of our member centers or of like any one department within our member centers. This is really the work that our entire communities need to be engaging in. We need strategies that are going to address the relationship, community, and societal levels of this model. So one way of doing this is to take a multi-sectoral approach to ending sexual violence, or to use multi-sectoral coordination. So this is a definition from a health policy project document. This refers to deliberate collaboration among various stakeholder groups and sectors to jointly achieve a policy outcome. By engaging multiple sectors, partners can leverage knowledge, expertise, reach, and resources, benefiting from their combined and varied strengths as they work towards the shared goal of producing better health outcomes. So a few key points from this definition, and this definition sort of refers to like a policy outcome, and certainly there are many policy solutions that we care about related to sexual violence, but we can also think about a multi-sectoral approach to improving services in a community, or to ensuring widespread adoption of a specific prevention strategy, things like that. It doesn't have to just be policy. Some key things to be aware of when it comes to using a multi-sectoral approach. This does not happen by accident or unintentionally, right? This requires that folks get on the same page. Folks are deliberately like setting up conversations and checking in with different stakeholders to see how they would approach a certain problem, what can they bring to the table. It recognizes that different sectors have their own valuable perspectives on sexual violence, right? For those of us here who are coming from the anti-sexual violence work from like a member center, nonprofit place, right? Our approach to preventing, responding to sexual violence is different than an approach from, say, law enforcement, or from folks working in like a medical facility, from folks working in an educational setting. So people have different perspectives, and all of those are valuable. All right. So we're going to break this down. We're going to spend a lot of time talking about this because one of our goals, Jesse and I are hoping that after today, and we will spend some time actually talking about this, you all are going to walk away from this training with some new goals of how to better engage in a multi-sectoral approach. And we'll give you some suggestions for how to do that. So first, let's think about why this is useful specifically for sexual violence. We know that sexual violence is a complicated problem. There are many different routes to sexual violence, why certain people choose to harm others in this way. And no one group of people can be responsible for addressing all of those root causes, right? Nor can one group of people be responsible for providing like all of the prevention or all of the response and solutions. This is also a great way to address sexual violence because it is bringing together people who are already doing the work in their own different ways, right? We know that there are survivors are interacting with lots of different people across our communities. They're not just coming to our member centers, to anti-sexual violence agencies. They're also going to the doctor. They're also going to school. They're also sometimes talking to the police. They also have just jobs that are completely unrelated to their experience as a survivor, right? So by bringing folks together from all of these different places, we just expand our reach to work with more survivors, to work with more people who can be a part of prevention activities and keeping our community safer. We also just get access to way more resources when we have people at the table from different places, right? We all know that we're working with limited funding for our own individual agencies and the work that we're trying to do. And so the more people we get on board that have access to greater pools of funding and just more people with more knowledge, the more likely we are to be able to do this work well. And there's also a higher likelihood, this sort of goes back to the conversation we were having before about why we do such a poor job surveying and capturing data about sexual violence. When we've got like one group of people, which might be coming from like a predominantly white institution or an institution that mostly works with cis women or whatever, then that's the approach that they're going to take to solving the problem, right? And so the more people we have around the table, we're likely to design better survey questions to actually capture some of this data more accurately, or we're more likely to be able to talk about, okay, this is the information we need to capture. What are the other strategies besides just doing a big survey? How else could we get that information, right? More ideas. We're more likely to develop culturally relevant strategies that are actually going to achieve what we're trying to. But we all know that this is not really how the work is done a lot of the time. And while there is certainly good collaboration happening between agencies and different sectors in Connecticut, I want us to just think about for a second the consequences, and we're going to do this activity as a group, the consequences of approaching the work in a siloed fashion, right? Or just one single group of people trying to solve the problem of sexual violence. So what we're going to do, I'm going to move us over to like a little brainstorm group situation. And we're you folks can share like via the chat, or you can feel free to unmute yourself and share. I have some questions for you all about how to, sorry, while I get this figured out, what it looks like when we approach sexual violence from this like single sector approach. And first we need to just we're going to pick just one sector to focus on. Does anybody have a suggestion? We sort of listed a few before. What's one group of people that deals with trying to prevent or respond to sexual violence? Who do we want to talk about?
The Alliance.
That's true. Coalitions, like the Alliance specifically, and coalitions is one. Some folks in the chat put in law enforcement. I do think law enforcement might be the easiest way. It uncovers some of the problems very clearly. Marisol, I would love to have a conversation about what happens if it's just the Alliance at some point. So let's do that. But why don't we go with law enforcement for now? So, okay. So my questions for you all, you all can see this up here where it says name of sector. I'm doing this the right way. Okay, great. So we're talking about law enforcement. How does law enforcement define sexual violence? What would they say that it, without, nobody needs to pull up a statute here or anything, but like, how would law enforcement define sexual violence?
Anything that like breaks the law, you know? Yeah, like
No,
Marisol
they don't.
said, legally.
No, they don't know how to do that neither. I hate to say it, to me, they do have almost like the television-like idea of what sexual assault is. Some of the responses that we get, oh God, it's sad that I basically have to tell folks, listen, don't worry about what the police say. Come back to my office, come back to the campus, and we will go from there regarding accommodations. I mean, I have to tell this to employees. Oh, the restraining order, they said there were no grounds. We don't care. You have to come back to us. There is such a high threshold legally. But then how police are trained is really poor. And they very much have that stereotypical ideal in their head of what sexual assault has to look like. And when they tend to see a lack of injuries, especially if they tend to see a victim that is very forward or not acting as, in some broken, weeping manner, they don't show up. And again, not statistically, but just from my work. I mean, from young adults, right, teenagers, all the way up to employees, and us having to say, no, we'll accommodate that. You know, we want that person's picture. We can ban them from our campus. Please work with us. It doesn't mean they don't care, but when it comes down to the nitty gritty and the application, a lot of times it just falls through. Yeah, it really does. And that means that the prosecutors don't ever even get a chance to look at it and say, yes, this is something we can take up. Yeah.
Something I would add is that it's based on statute rather than harm. And that's how it's categorized.
All right. Good job, everyone. My next question is, how would law enforcement define the causes of sexual violence? Broadly, what do they think causes people to harm people or for this to happen?
There's a lot of victim blaming that goes on. What someone was wearing, if they were using substances, if they had, you know, maybe previously been in a romantic relationship with the offender, whatever it is.
Drugs and alcohol, this is in the chat, drugs and alcohol, wrong place at the wrong time, underage drinking. Risky behaviors, drug use, infidelity, bad decisions, what the victim was wearing. Power and control.
All right. So my next two questions for you all. Knowing all of this, knowing how law enforcement might define and also think about the causes of sexual violence, what sort of solutions might, if this was the only group of people responsible for dealing with sexual violence, what sort of solutions might they want to implement or have the ability to implement? And someone in the chat asked if we're just talking about police or does this include probation and parole? I don't know. We can think about the whole criminal legal system here. I get that there's some differences, but whatever folks want to share, we'll put it up here. All right. So better training, I'm seeing in the chat. Better training, Melanie, do you want to say better training for who? I'm saying protective restraining orders.
I don't know if it has been defined by case law, but when you look at the statute, we really need to train on the definition of use of force, because that is where a lot of law enforcement and that whole community saying, well, there wasn't a use of force. You know, so what's the issue? And I think we look at use of force in a much broader definition than how they're applying it. And if there could be some type of training, particularly, I hate to say though, it can't come from our community because they won't listen to that. It really does need to come, when we talk about that multi-approach, it does need to come down out of the judicial branch. It needs to be DCJ coming in and saying, look, this is use of force. And when and where these types of cases have been brought to us, we have absolutely still found that that was use of force. And that use of force doesn't have to be equated with physical violence. I think absent that, it's why they're able to say, oh, no, 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 I know that won't stand up in court. You know, but I think that also then brings into question how our judicial system also looks at it. But
so for folks, because I'm seeing a lot of responses in the chat here about like training, like, you know, folks need training on being trauma informed, need training about not victim blaming, et cetera. Do we think those are solutions that like folks working within law enforcement are going to be saying, yeah, if we want to fix this, then like our people really need more training on this? So that's the question I'm asking. Maybe I wasn't being clear. Like if it's just law enforcement that are trying to prevent sexual violence, what are they going to say we need to do? So we've got increased policing, punishing folks rather than providing therapeutic services for problem sexual behavior. Let's see. So there's a sense that folks coming from, which this makes sense, folks coming from a law enforcement background are going to be really reliant upon law enforcement solutions. And in fact, those are really the only things they have any control over, right? So things like restraining orders, protective orders, increased policing, if the idea that if there are just more police everywhere, then nobody's going to be sexually assaulted. Punishing people, having maybe a really tough on sexual violence in terms of punishment approach. And actually, Bridget, your comment about self-defense is really right on, because actually there are many police departments offer self-defense classes, or like they're the folks that might train on this. So I do think probably they think that they view that as one solution. All right. So the risk of asking a very obvious question, and I'm seeing, yes.
Lakia, have you heard that before?
I have not heard that for sexual assault, but I heard it for domestic violence.
Yeah, exactly.
Situations.
Yeah. Okay. So the last piece of understanding like why we can't do this work in a silo is for us to think about, so if this is the approach we took, what is not going to happen, right? What are we going to miss out on? Who is not going to be served? What are the limitations?
I think, like if you don't look at what everyone else is doing, why are we spending the minimal amount of money that we have on, just doing something that somebody else is already doing? Why not collaborate? Yeah.
So lots of sort of duplicated responses where we're all sort of just doing the same thing and nobody's working together. So it's sort of like a waste of resources and funding potentially.
Kelsey, Sunny put in that root causes aren't being addressed or be missed.
Yeah. Yep. There's going to be, so Louisa's comment about self-defense, that like folks are, if you're assaulted by somebody that you know, probably even less likely to find self-defense to be a useful strategy. So we're going to have just whole groups of people who don't get the actual prevention strategies that are going to be helpful to them.
I'm scrolling up and pulling some of the things that people said from the last question, because I think they actually fit here. So some things we missed also, like Sunny had said, collaboration with advocacy centers, like that doesn't happen. Someone also had said, there's something else I wanted to pull in here. Nikki had said individual choices rather than systemic. So I would say I would miss like addressing this from a systemic perspective versus individual.
Something that I thought about is that I'm from the Rowan Center, and my colleague Malin is also in here with me too. When we went to observe our education coordinator to do a training with the police department, and they weren't very like invested or interested in the subject matter of like how important it was, because like a lot of them were either like talking to each other or like making jokes or like on their phones. So I think like them not knowing how important something like this is like also something to take into consideration too.
Yeah, I meant it when I said, yes. I don't care if we are the masterminds behind and we put other people forward in authority as puppets, but we do need to stick our hands up the back of like the Division of Criminal Justice, Post, and those other places, and it needs to come from folks that they listen to. You're not really gonna get too many forces that are gonna sit there and thumb their noses at DCJ is the Division of Criminal Justice for anybody who doesn't know. Those are our state's attorneys. I really would go that route if we had to, and I think it would give us better results. I wouldn't even do it with our local legislators. Somewhere between Post and DCJ. Maybe for the administrators, if we wanted a trickle-down effect, it could come out of the Office of Policy and Management, because they give them the justice assistance grants, and your chiefs and your administrators would understand that now we're tying that type of education with their purse strings. But I hate to be so forward, but I think absent the leverage, yeah, no, exactly what you got. I mean, it's always been that way. We've been trying to do, if you do community outreach and you've been training police for like the last 10 or 15 years, when we show up, they just don't care. I'm so sorry. Yeah.
So then, yeah, so we're not, and this is to, I think, Danielle, what you were just saying, that we're not engaging the people. There's maybe some people working in law enforcement that view this as a problem for their own reasons, but we're not engaging the people who genuinely care about ending sexual violence because they, want fewer people to experience this kind of trauma in the world, or for, the reasons, or look at like the economic costs, the cost to our communities when sexual violence is highly prevalent, right? So we're just not engaging the right people if we're only focusing on one group, right?
Or see it as part of their responsibility, right?
Right. All right. Nice job, everybody, with all that. So obviously we could ask those same questions about any one sector, including our own, including those of us that are working for our member agencies, or working for the coalition. We cannot be the only people tasked with ending sexual violence in our communities, because we are one group of people with one perspective, even though there are many of us in this field and we all have our individual own perspectives on what works and how to define the problem. We're just not effective when we do this work in silos. So go back to this. All right. So if we are going to do multi-sectoral work well, this is one way that it might look. So this is just one model we do love this sort of circle-like approach here. This one looks more like a star, but when we do multi-sectoral work well, these are some of the key pieces of it. This might involve creating, I'm sort of starting at the top where it says design. This sometimes involves creating new systems. In fact, in many cases, we are having to build something new because we don't naturally or just accidentally approach this work from a really collaborative place. This might involve setting up new processes, bringing new people together that are not often talking to one another. This work, when done well, involves a lot of evaluation of the work that we're doing and continually reflecting upon, are we doing things well? What do these relationships look like? And are they working the right way? Do we have the right people at the table? Who are we missing? Also capturing success, which means we have to sort of agree on what does success actually look like? What are our goals? What do we think we can achieve here? And how are we going to know if we've done that or not? We are acknowledging that we need to change something, right? And so some of this comes down to folks also being on the same page about what the problem is, how we are defining sexual violence, and that comes down to the defining piece of this as well. So this is some of what we just talked about, but For this to happen well, we need a culture of collaboration. We're going to talk about why this is difficult in a second, because I'm sure some of you are thinking like, this sounds really good, but it's really difficult to do in practice. We know that. Multi-sectoral approaches require regular communication with partners, shared understanding of the problem, and cross-sector commitment to specific goals. Collaboration with community partners needs to be built into the process. So at some point, if we get this going, that means this is just a regular part of our process. It's a regular part of our own, like our job descriptions, right? That's one way that you could think of it, that you are expected to collaborate with people outside of your department, outside of your agency, outside of your field. Sectors need to be supportive of one another's work, and we need regular assessment of the partnerships and the outcomes of those partnerships. All right, so we're gonna just do another quick brainstorm here using the chat, or if you want to unmute yourselves. Who are our stakeholders? So when it comes to anti-sexual violence work, who do we want to be at the table? There's one answer up in the corner there, if you're looking at what we're going to talk about next, but. Survivors, thank you, Sarah. Legislators, community members. Parole, probation, school administrators, parents, families. Public service announcements might be an outcome of doing this, unless maybe PSA stands for something that I am not thinking of, Marisol, if you want to spell that out. Educational spaces. So yeah, for folks working in pre-K through higher ed, right? Really important collaborators. People who have done the harm, right? We do need to understand, like, why is that happening? What do we need to do to prevent that from happening? Churches, community leaders, prosecutors, police, law enforcement, doctors. Great. Awesome. So this is a huge group of people. So again, we can all be thinking about like why this sounds like it's going to be really difficult to do. Families of survivors, social workers, colleges. Yeah. And so Louisa, you're getting at that's like a potential outcome, right? When we've got folks from higher ed at the table and we're talking about policy, right? We do actually have this policy in Connecticut, but you know, if we didn't have a policy saying all higher ed institutions need to be educating folks on bystander intervention or effective prevention strategies, because those folks weren't at the table, we just might not do that. Great. Okay, thanks everyone. So we're going to focus for a little bit now on one specific group of people that I think are underutilized by the sexual violence, anti-sexual violence movement, and are super valuable for our communities. And that is our local health departments. So many of us may not have a real clear idea about what our local health departments do. Although, again, because of COVID, we might have a little bit more familiarity because the whole public health world has gotten more attention in the last year and a half. And we're gonna talk specifically about Connecticut in a second. You'll get to see actually where how we're broken down by like region in Connecticut for the most part, health departments. But in general, what local health departments do is a lot. All of the functions of public health that we talked about at the beginning of this presentation, on a local level, these health departments are the people responsible for carrying those things out, right? So all of the push for getting folks vaccinated right now, that's coming from our local regional health departments and state health departments as well. They are concerned with things like food safety, preventing and responding to infectious disease, trying to encourage folks to do things to prevent chronic disease, injury and violence prevention, environmental health, emergency preparedness. So all the stuff that we talked about at the beginning of this presentation. So what does this look like? Oh, so this is I put this in here, the Connecticut Department of Public Health, which is our state body for doing this work. This is their mission to protect and improve the health and safety of the people of Connecticut by assuring the conditions in which people can be healthy, preventing disease, injury, and disability, and promoting the equal employment of the highest attainable standard of health, which is a human right and a priority of the state. So while it doesn't say specifically in here, you know, if we sort of look at the injury piece of this, that's maybe where the sexual violence stuff falls into. This preventing sexual violence is part of the work of both the Connecticut Department of Public Health and our local regional health departments. But I don't think that they're a group that we have engaged all that often. So that's why we're talking about them today. So here's what this looks like in Connecticut. And I know this is kind of small. I'll send out a link to this. All this stuff is pretty easy to find on the state website, but I'll make sure you all have access to this. So you can sort of see that where there are numbers, those refer to specific health regions or health departments. So I, for a while, lived in New London. And so this whole region that has number 9 in it, that's the Ledgelight Health District. So all those towns sort of in the southeast corner of the state are under the same health district. There are some towns, I currently live in Middletown, we have a full-time health district just ourselves, or a full-time health department on our own. But generally folks are broken up into regions other than sort of the southwestern part of the state. Some things that our local health departments have done in Connecticut, this I think is one campaign a few years ago that many of us probably saw, the Change the Script campaign, when we were doing a lot of work around preventing opioid overdose. And this was really, this probably is a really good example of like a multi-sectoral approach within the state of Connecticut and across the country, because this wasn't just, let's do a bunch of education for young people about why they shouldn't take prescription pills or abuse prescription pills. It was also, we need to look at why are doctors prescribing so many prescription pills? What other options are there for people besides taking pills to manage their pain? There certainly was, these are some of the things you might have seen that are a little more like public service announcement type stuff or educational type stuff. But there were people there was a criminal justice or law enforcement approach to this problem. There were a lot of people trying to respond to the opioid crisis in Connecticut, but local health departments were the people like working on these campaigns, putting out these billboards, stuff like that. So one question I've got for everyone, if you know, have you or your agency worked with your local health department on something? And if you have worked with them, maybe you've worked with them in a previous role, maybe not at your current job, share with us what that was too. How are folks working with local health departments?
And if you never have, you can say that too.
Yeah.
We recently worked with our health department for vaccines and things like that, for us getting our vaccines. And one of the volunteers is actually one of our board members.
Cool. That's great.
Louisa, are the roundtables, the Department of Health's, that they're hosting roundtables?
So it sounds like there's been some tabling and some training specifically around vaccines or, getting our clients vaccinated. Oh, cool. So there's a little bit of maybe cross training or like reciprocal, we're training health department folks on how to work with somebody who's disclosing, and maybe they're training or talking to some of our folks about their own priorities as well. Okay. There is much more we all could be doing to engage our local health departments. It's awesome to hear that some of you have had actually some contact with your district. We are hoping that people are going to walk away today having an idea of something else you could be doing with your local health district. All right, but before we do that, let's come back to the conversation we started to have about why this type of work, this multi-sectoral approach, why this is difficult. So we are going to go back into breakout rooms for just a few minutes here and just do a little bit of brainstorming. When you think about all the things we've shared about a multi-sectoral approach to ending sexual violence, why is that going to be challenging? What are some of the barriers to that? And we'll do 4 minutes again. All right. Thanks, everyone. I'm sure this is sort of what we came up. Oh, whoops. Oh, I guess I didn't put that in there. All right. So do folks want to share what you came up with in your groups, just briefly? Like, what are some of the barriers here while I pull our slides back up?
Anyone from our group want to jump in? I can start us off, and then if folks want to jump in if I miss anything. We talked about there being some like gray area and it not being as straightforward, like the components of sexual violence and like who gets involved and whose responsibilities it is. We talked about from an education perspective and going into schools that there's like a level of denial of not happening in their schools or working with policymakers, that it doesn't happen in their among their constituents and their catchment areas. Talked about people having challenges using the correct terminology and that seeming offensive to them to talk about like genitalia and other things that might be triggering or just challenging. We talked about previous trauma maybe getting in the way. What am I missing? There were a couple other things that folks said. Public health departments and stuff being underfunded, under-resourced.
Anybody from my group want to share anything? We came up with a few of the same things, and anything anybody wants to add?
Just that many organizations are involved. And so it's difficult getting everyone together and on the same page.
And I think a good thing you said was competition sometimes because of mutual grant funding kind of things.
Yeah. It is the, oops, sorry, did I interrupt someone? Okay. I don't want to minimize the just the like logistics of, we all know how difficult it is to schedule meetings with large groups of people, right? So even that is just a huge barrier that we've got lots of busy people we know we got to get them there, but it's hard, right?
Someone mentioned the mutual grant issue. One of the things that I found really interesting is all of the language that was given to colleges, but we're not part of any formula grant. Universities are statutorily held to this, to engaging in certain behaviors and having certain programs. But if you look at the other groups, they're part of a formula grant. Connecticut Alliance is part of a formula grant that comes down through the state. I understand they have to apply, they have to, but for the most part, it is such a formula that if you screw it up, the DOJ will actually call up the Office of Policy and Management and say, why don't you have money going to your statewide alliance, and what do we need to do to fix it? Universities aren't any part of a formula grant. Therefore, the budget and the money that goes over to those programs is truly at either the whim of the legislature for state universities or at the whim of a college president and board. So you can have a budget that goes anywhere from $5,000 all the way up to maybe 60, and it's still subject to being taken. And I've seen that happen. So that you might be left with the title of a Title IX coordinator because they have to do that, but with like a $2,000 budget to handle a campus of 5,000 or 6,000 people. I do think it should go, it needs to be folded in the same way police, shelters, prosecutors, everybody else is folded in. And it doesn't need to be fully funded, but a portion of that to me should. And it would even give you guys more teeth around enforcement on colleges. We'd also get TA from the Department of Justice, TA from the DOE around Title IX. They actually won't give it. I've called them and said, can you please come help us with this? And they're like, nah, we don't do Title IX technical assistance. Okay. Yeah, when I worked at the state, I got way more interaction with the Department of Justice than I have the Department of Education. So to me, that's a huge barrier because you have really left it up to a private sector to decide how much money goes into it.
Yeah, and that's part of the investment piece we were talking about at the beginning, right, Raina? Like where our funding priorities show a lot about what we care about. And we have known for a long, long time that colleges and universities are an important part of the preventing sexual violence puzzle, but our funding priorities don't reflect that necessarily on a federal or a state level. All right, so we wanted to just briefly show you all a few examples of good multi-sectoral collaboration that has to do specifically with sexual violence. So I'm going to actually pull up a website. So there is, Jessie, do you want to talk just briefly about what Together for Girls is?
Sure, happy to. So Together for Girls is a public-private partnership that was developed maybe now like over a decade ago in response to some work being done mostly through UNICEF, the United Nations arm that looks at children's health issues, and the Centers for Disease Control and Prevention, and a couple private entities that really wanted to support really examining a little bit deeper what the experiences of violence against children really looks like globally. And it started really with a request from UNICEF and the government of what's now Eswatini and formerly Swaziland to really look at what the extent of violence against girls was, because they were hearing a lot of anecdotal reports of high levels of violence against girls in school settings. And so they wanted to be able to have like some more teeth, basically, to steal Farina's term, to be able to say, you know, we need to act on this, and they basically wanted zero tolerance policies, I think is where it was. But they wanted to be able to say, hey, look, we've done these different school surveys, and we know we need to take a little bit of a broader look at looking more broadly at the country as a whole to be able to really be able to assess what's going on. But we think there's a humongous problem in schools. And so that's where this it launched from, was this initial survey, and then the organization Together for Girls kind of developed a little bit in response to that to be able to help facilitate those surveys actually moving forward, but also to bring in additional arms. So a policy, to be able to do more policy work, to be able to do more advocacy work, to be able to really push on prevention and response. And so they kind of developed as a way to kind of convene and to help kind of push these other priorities in terms of like, what do we do once we have the data? So I can speak a little bit more to kind of the process if you want, Kelsey, and then we can jump into some of the examples.
Sure.
So, and just to give you all a little bit of background. So prior to my work here, I was at the Centers for Disease Control and Prevention, and I worked in the Division of Global HIV and Tuberculosis. And as part of my job my work was really focused on addressing gender inequities in HIV prevention, care, and treatment. And as part of that, I was really looking at issues of gender-based violence. and part of my work was to help to integrate into the work of countries that received the President's Emergency Plan for AIDS Relief funding, PEPFAR funding, to really start looking at what does it look like for those, especially girls and adolescent girls and young women who are experiencing high rates of HIV and carry the burden of disease across the sub-Saharan continent. Where is violence and like kind of interplaying with that? And so a couple of the countries had already done violence against children surveys. Many who had not were kind of pushed to start thinking about that. And that it wasn't done alone, like it wasn't done kind of by a singular entity. What was required of any country that was interested in embarking on that, on the Violence Against Children survey, was that they had to internally, first of all, they had to kind of put the requests together themselves to Together for Girls and the Centers for Disease Control and Prevention. They had to create a multi-sectoral task force to inform the process. And so they got to choose kind of what that looked like. But really, for many of those countries, it was some combination of a variety of ministries in their country. So the Ministry of Health, many of them have like the Ministry of Gender or Women and Children, and sometimes sports and other kind of random things lumped in there. Education, justice, I'm trying to think of who else was that. So it was like, this kind of the usual suspects that we kind of talk about, but they were all required to kind of be part of a group that would help review the survey, make determinations about what, if any, cultural adaptations needed to be made to the survey, what languages the survey should be administered in, what the rollout and timing of the survey should look like based on school schedules and stuff. It was a house-based survey, it was done in the community. It wasn't a school-based survey. So they, as a group, would make those determinations. Then they were required to stay together. They had to make a commitment. They still do. This still happens. They have to make a commitment to using the data, right? So part of the process is that they administer the survey, they come back together as a group, and they have a few days of a data to action workshop, where they kind of workshop and look at the data together and go through what we helped to develop was a tool for helping them to deal with their data. Because what was happening at the beginning is they would get all this data and they were like, what the heck do we do with this? Like, we don't know what to do. Like, yes, it's all good data, but how do we respond to this? And how do we know what parts apply to our particular sector? So we created a tool for them to be able to sit down as a multi-sectoral group and be able to look at different components of the data to be able to see, oh, okay, so I see this piece and I see this is happening, and we see a lot, like this amount of violence occurring to and from school. So the education sector, along with maybe the Ministry of Gender would work together and be like, okay, so what can we do to be able to help from a prevention standpoint so that girls aren't being attacked on the street on the way to school, right? So they would start kind of brainstorming, how do we use that particular data that's showing us that this is like a very clear time of day and a vulnerability for girls. So then they had to put together an action plan. And Kelsey, I think, has pulled together some of what has come out of some of those action planning processes, and then the implementation of some of those plans. And we thought we could share them with you because there are so many great lessons learned from around the globe.
So I will send the link to this website. They're very easy to find, Together for Girls, but in a follow-up, basically, and I'm only going to just show us one because we're a little short on time, but you can look at specific countries and what they've done. And so Tanzania is one example where this is some information about like the data that they collected when they did the Violence Against Children survey. You can look at the report, but then if you scroll down, you can see they have developed an action plan. And I think, right here, you can see these are some of the specific actions that came out that they have done, right? So they established guidelines for these gender and children's desks. They established one-stop centers and national guidelines, development of various district level child protection system. If you click on any of these, you can see more details about them. They established these clubs, guidelines for budgeting for child protection. So when we do multi-sectoral collaboration well, And this is what I love about Together for Girls is that it really was collaborative the whole way, right? Like the initial data collection was collaborative as well. And then they came up with concrete actions that they have, and they continue to do these surveys. So you can, there might be some countries that have done several, so you can sort of look and compare, like, or they've done two, sure.
Well, it's expensive.
Yeah, you can sort of compare, okay, that when they did it the first time and then they implemented something and then they did it a second time, like what did they learn between the two? So Tanzania is a great one to look at. The other two that I'm not going to show us right now, but I had pulled out, Cambodia and Zimbabwe are also, both have some really great examples of multi-sectoral collaboration. I also just love to remind us that we don't, in the United States, actually serve as the model for any of this work necessarily, that we should be learning and pulling good information from other countries, right? All right, Jesse, I think I'm going to turn it back to you. Just let me pull our slides back up. Oh yeah, do you want to talk about the state health assessment?
Yeah. So this is one of the things that Kelsey and I had talked about that we think is so important. And this is, and I don't think we mentioned this, but what we would like to do is we're also are going to work with our colleagues at Connecticut State Department of Public Health and reach out to the various health districts across the state to try to do a similar training with them that really speaks more to like what we would like to see their responsibilities be around jumping into this work, right? And not independently. And part of what we want to do is we want to encourage them to be working closely with all of you, right? We, like at the Alliance, like we try to work with at the state level with the state health department. We would love to see the local health departments working more closely with you and supporting your work. And one of the things that we will show them is that the Department of Health puts together I think it's every 5 years, they put together another Healthy Connecticut. And they do this by doing a broader state health assessment and then putting together kind of an action plan for the state as a whole. And I wanted to highlight that in 2019 is the most recent one that they did, and they're still kind of drafting what the next plan, the state health improvement plan is what it's called, is going to look like for this next round. But in the state health assessment, the chapter 6 is on behavioral health, trauma and injury, and does include information on ACEs and sexual violence, intimate partner violence, and highlights the really important associations between sexual violence and other health issues, especially among young people. For those of you who have done, who have been involved in YPAR, some of the YPAR stuff is actually highlighted in the 2019 a report. And I think, I pulled this quote right out of it. And I think like, this is so important, and they have it in their state health assessment. Sexual violence has far reaching effects on society and is a significant public health problem in Connecticut. Yet I am not aware of any of the health departments that are doing anything to address it. And so I think it is incumbent on the health department to try to make some inroads, right, to be doing this work. And I don't think they can do it alone. They're going to be lost at a local health, at local health departments are going to be a little bit lost in doing this, right? This is not their area of expertise, and they have lots of strategies and techniques and maybe have really good connections to maybe developing these multi-sectoral task forces and groups, but are going to need a lot of help from all of you, right, to be able to venture down this path. And some of this, like with working with them, is going to be using some of their terminology, right? It's going to be helping them to think through, like, what is it that they're already doing, or what do they know about public health that you can kind of share with them from a sexual violence standpoint that's going to kind of ring true to them. And in public health, and this is in the model that Kelsey shared, the public health model, we talk a lot about risk and protective factors, right? We want to understand what puts someone at risk for a certain disease, for a certain health outcome, and what sorts of things can we do to protect them, right? And because in public health, as we talked about early on, public health departments are responsible for prevention of various health problems. So putting in place what they know works, as well as doing health promotion. So that would be kind of helping to develop the protective factor side, right? So I think in terms of this piece, what I really wanted to highlight, and I want us to be thinking about as a coalition, is like, where are there shared risk and protective factors from sexual violence with other health issues? So that might be other types of violence, and I'll talk about that in a second. And it might be other issues that we see being incredibly pervasive. And I think that there are many that we look at a lot of different health issues in terms of, if we look at opioid use, if we look at other substance use and abuse, if we look at folks with mental health issues, we know there's a history of trauma in so many folks, right? So we look at some of the things that people experience, and this kind of brings us back to the ACEs conversation. There are a number of shared risk and protective factors when we look across a number of different health issues. And there's no reason we should be trying to go it alone. So what I just kind of put here was like some of those pieces. It's okay, Kelsey, you can move or not. That looking at and trying to address shared risk and protective factors really recognizes this piece of co-occurring experiences. I mean, it's like things that are happening at the same time and that could be addressed simultaneously, right? It really identifies some more opportunities. We just talked about how sexual violence is so underfunded, and all areas of violence are underfunded, but so are many other things that the local health departments are probably trying to address. So there are scarce resources. So how do we maximize the work that we do to be able to do better with less, right? And part of that, I think, is looking at the ways that these areas overlap, these problems overlap. And then I think this also allows, and this is part of the public health model, is that the understanding shared risk and protective factors really allows for developing better or building off of and adapting or adopting existing primary and secondary prevention interventions. And this is an area as a sexual violence movement that we do probably the worst of all of our work. We know how to respond to the sexual violence. We know how to provide good supportive services. We are not great about preventing. Right. And this is one of the reasons we continue to not see numbers go down, is because we aren't doing a great job of preventing it from occurring to begin with. And again, we can't do it alone, right? So as a movement, like, this cannot be solely our responsibility. So the connecting the dots piece, that the CDC developed a document specifically to kind of speak to the way that we need to think about looking at shared risk and protective factors across different areas of violence. So this is like very specific to the area of violence, and the Division of Violence Prevention at CDC was the one who developed this, thinking about, okay, so we know that when we pass funds down, they're limited funds to states. So how can you all be thinking about in your states, like, to maximize the resources that you get? There are things that you could potentially be doing. Kelsey, I think if you click forward, you can zoom in a little further. So this is just I just put this in here to show you some of the examples of what they talked about. So in the document, they kind of have this great table where they kind of map out in this matrix the different risk factors that have been identified through various studies of violence. And then across the top is these different areas of violence. So child maltreatment, teen dating violence, IPV, SV, youth violence, they talk about bullying specifically, suicide, and elder maltreatment. And you'll see where there are common risk factors across these areas. Right? And so if we start thinking about how we address these risk factors in prevention interventions, we're not going to be successful in one area. We will likely be successful across multiple areas of violence in terms of prevention. Same goes for protective factors. I think if you advance one more, Kelsey, yep. So you'll see they also have a list of protective factors, and they break them across, like, you'll see that they categorically, this is the social ecology, the social ecological model that Kelsey talked about, from an individual, relationship, community, societal standpoint. So they kind of go through those different rings of the social ecology to be able to talk about, like, where these different risk and protective factors kind of live. So, talking here about communities and coordination of resources and services among community agencies, access to mental health and substance abuse services, community support, and connectedness. Connectedness is huge. And then the work that we do with schools, whether it be K-12 or higher ed, this idea of connectedness to your community, and that could be your school community, is so critical. And schools want that, right? They want kids to feel connected. They want kids to come in and be present. And so I think that's a big selling point that we don't really capitalize on quite enough. And then the last piece, again, this is all sort of saying the same thing in slightly different ways, but one of the things that has always occurred to me in terms of especially doing work with youth is that we continue to try to do this work in silos. And this is what, Kelsey and I were talking about earlier on with the multi-sectoral approach. Again, this is just one more way of thinking about it. none of the individuals that you serve, the clients that you're serving, the victims and survivors that we see, no youth that I know of ever experience one particular health problem in a bubble. There's a whole constellation of health issues that they are dealing with on a regular basis. Yet we continuously try to do things in silos. Health classes talk about one topic at a time, right? And we talk about, like, we get funding that is specific to sexual violence. We see the work that gets done around the opioid epidemic was solely opioid focused. Like, why weren't they thinking about how do we look at what the risk factors are for opioid use and abuse? So all these ways that we kind of have missed the mark on various occasions, I think lend themselves to lots of lessons learned and are really important, and are also opportunities for us, right? How can we build off of all the work and all the funding that has gone into opioid epidemic? I think there's tons of opportunities there, right? For thinking about where substance abuse and sexual violence or mental health issues overlap, and where we see opportunities for collaboration with our public health departments and other community partners.
All right. So we are just about out of time, but there is one sort of takeaway piece we want you all to think about for just a second. So feel free to share in the chat or to unmute and share. We want everyone to come up with 2 action steps that you could take as a result of what you've learned in this training to increase your collaboration across sectors, across community partners related to sexual violence. One of those steps, we would love if one of those things could include your local health department or health district. Okay, so 2 actions, they could be as simple as like, I'm going to make a phone call to this person, or I am going to figure out what health district am I a part of and who do I need to contact there, right? Like, they don't need to be big, giant, I'm going to convene a meeting of all these people. 2 action steps that you can take. So I'll give you a minute to think and feel free to share. Thanks, Alexa, for sharing networking with other rape crisis centers and contacting local health districts. Awesome. All right, Marisol said to get an audience for community education at her church and to contact our health department. Excellent.
You know, one of the things that came up in our group, I think Sarah had brought it up, was this piece around denial of people thinking that the sexual violence is a problem in their area. And one of the things that we can work together with you to do is to help you identify, you know, who are some of those champions that you need to identify and what do you need to provide them in terms of information to help them realize that it's a problem. So looking at data, right, in a new way might be something else that we as a coalition start to venture into. And who do we need to provide that data to help them get on board?
Yeah, and I think, Sophie, that's what you're sort of addressing with your comment about creating a presentation that emphasizes the statistics of the prevalence and the cost. Because you're right. I mean, people need to hear different information to get on board, right? We can't approach everybody the exact same way. All right, working with local PTO, health departments. CJ's already doing that. Love it, looking up the health department. More outreach to churches. Excellent. If you feel stuck, I think there are some folks here, obviously we've got a few folks that are from the same agency here. So this should be a conversation you're having with other, you know, with your colleagues, right? And if you're feeling stuck, feel free to contact whoever at the Alliance you want to contact, because this is certainly technical assistance we can provide in terms of building your network of people in your region, right?
Yeah, community meetings, looking how you can be a part of community meetings. Yeah.
Awesome.
See, if your public health department, I haven't seen a lot of this, but I'm not out and about that much. But if they post having a meeting for something completely unrelated, we can go and be like, hey, we do this work. who at the health department could we connect with? Yeah, Rena, at a national level. Yeah, that's great. Mm-hmm. Sure, Louisa. Yeah, we can provide stats, slides and stuff. Absolutely.
Some of what we're hopefully an outcome of today's presentation is also just sometimes it's hard to know where to look for stuff, or like what information is on Connecticut's website, what information is the youth risk behavior survey, right? Like that data is really useful to all of you in advocating for more money for prevention, to be able to get into some of the schools and the other spaces that you want to work with youth, right? But it's just knowing where all of that information lives. So we'll put together a list of like any resource we think we shared today that might be helpful. I am just pulling up the evaluation for today's presentation that I am going to drop in the chat, if folks would take that when you've got a second. And we're so happy to have everybody here today.
Thank you everyone for coming and for participating. We were so excited to see such a good turnout for this, and look for us to do a second part of this to get to those last two kind of boxes of the model that we kind of talked about. We'd love for you to come back and engage with us again. This is great. And as Kelsey said, we'll send information out when we, as like a follow-on to everyone who registered for the event. And if you have, didn't open up, if anyone has questions, and we can stay on for a few more minutes for sure. If you have questions or anything else you want to share with us, I'd be happy to. Oh, Rena, that's super interesting. I didn't realize that. Yes, Louisa, we could definitely do that.